Welcome to MAP, the bi-weekly market access podcast provided by Mars Market Access and Pricing Strategy, which is your healthcare consultancy in the German-speaking markets. Mars makes it as easy as possible for you to get your pharmaceutical, medtech, or digital health product to the market and, of course, get the price it deserves. My name is Stefan Walzer. I'm the founder of Mars and a health economist by training and working in the fields of market access, reimbursement, pricing, and health economics already since 2004. And now let's learn about the market access and reimbursement systems around the globe. Digital health, and especially digital health applications, are probably the kind of future for the healthcare market, at least an add-on to obviously the kind of drugs and other medical devices, diagnostics available in the healthcare system. As you might know, DiGAs, so-called DiGAs in Germany, so digital health applications, are available and can be made available and also be paid by the health insurance companies since now roughly 2 years. So meaning that is back to the year 2020. But it's not the only country which has implemented something like a DiGA pathway. We have also Belgium, who has as well thought about it years before, probably around the same time as Germany, and has implemented as well a very similar kind of process, not exactly the same. I think important here is basically that the Belgium environment has created a so-called validation pyramid, and that is basically consisting of different levels there. They have 3 different levels. The first level is quite simple, that the digital health application is a CE certified medical device. That's, I think, the kind of standard, very similar to Germany. It's safely connected, so that's again more into the kind of IT infrastructure. Also part of the DiGA pathway and check basically with the BfArM when you compare it and with Germany. And then you have the third level, which is a bit divided in a so-called 3- and the 3+. The 3- is basically that you are currently in the process of proving the social economic value and the temporarily financed then hence by the NIHDI, so meaning by the healthcare system. And the 3+ is quite clearly fully proven. Again, very similar to the German environment, where you basically have the fast track access opportunity for DiGAs, in which you could basically get paid by the social health insurance companies while you're still running your final DiGA study, and then afterwards, after another assessment by the BfArM and then a price negotiation, it is and might then be fully proven, hence also fully available and finally available in the healthcare system. Still important, obviously, what is the kind of step, let's say, from the first level, CE certification, I think, which is quite clear, into the second level. And then, therefore, especially also then into the third level, which is the kind of payment, where obviously all of the companies might be looking forward. So it's quite clear. M2 is then basically, so that the second level is then basically the safe connection. And hence, if you need to go or want to go into the third level, you would basically need to quite clearly fulfill the criteria for the second level. But I think a very important point is also that then your digital health application needs to allow a healthcare professional to diagnose, to apply therapy, or to monitor a patient, all from a distance via a medical device made for use by the patient in his or her own environment. I think also here is a big difference where we might have had already a lot of discussions, for example, the German environment. Monitoring is not necessarily a definition criteria, for example, for digital health applications in Germany. I think the important point is here also that in Germany, the DiGA, so digital health application, needs to be in the hands of a patient, so the patient needs to drive it. Here in Belgium, it's rather, it needs to be applied in the patient's environment. And that obviously includes as well the monitoring, and it's, I think, especially when you think about maybe risk classes 1 or 2A, which is also kind of definition for German DiGAs. I think even a monitoring would probably make sense to be applied for. But currently, this is still a kind of exclusion criteria when you discuss that with the BfArM, which is again here a big difference to Belgium. Another important difference is also when you have a deeper look on that level 2, the IT connectivity in Belgium. Here, not like in Germany, where basically there is obviously a kind of template which needs to be filled out and then sent to the BfArM. And basically it needs to be, let's say, self-explained as well to the BfArM that you, let's say, comply to those kind of criteria and requirements. In Belgium, the companies have to submit to a risk, or let's call it a risk assessment needs to be submitted, developed by an independent organization and included in the mHealth Belgium, after which they have proven to meet all imposed criteria regarding authentication, security, and the use of local e-health services by means of standardized tests. So here it looks that it's rather a bit more strict, or at least a bit more controlled, maybe to say, when you compare it with the German environment. Core question still remains: what is the impact basically of the clinical evidence? And I think this is also, besides the whole kind of, let's say, frame for the digital health application in Belgium, also a core question to my guest, Katrien de Groote. She is a Belgium expert, also consultant in the Belgium healthcare environment, with a lot of experience in different kind of companies across the last years. Perfect. Thank you, Katrien, one of the health economic and market access experts from Belgium. Today on the topic, that's digital health applications. And whoever is following us, I mean, we have obviously as well a kind of dedicated process in Germany since, roughly a year now. So it's now it's June 21. So in June 2020, such a kind of process was launched. And I was obviously as well happy to hear and see also that also in Belgium, something very similar has been launched. Katrien, could you maybe summarize and explain the process as it's currently been running in Belgium?
It's actually a process where you can register and since very recently get your mobile apps reimbursed. So the system did already exist for some time. It's actually a kind of pyramid with 3 levels. In the first level, you get actually simply a registration of your mobile app so that it's visible on actually an internet platform. So all the apps are get their kind of visibility. In the second layer of the pyramid, they check let's say the authorities check the interoperability of your device or of your app. Let's call it like that. And in the third layer, which is actually installed since the 18th of February of this year, it's you can apply for funding or reimbursement of the mobile app. So that's actually the 3 layers.
Okay, interesting. I mean, is this then just one kind of institution who is doing those 3 kind of steps, or are there different institutions being involved?
No, that's a good question. It's actually 3 different institutions. So actually, there is actually the mHealth platform who does the registration in the first layer. In the second layer, it's the FAG, it's the FAGG, it's the registration authority that is that's taking up the second layer process, and the third layer, the reimbursement funding, is taken care by the RECIF, so the payer body in Belgium.
Okay, interesting. So I mean, we have a 2-step kind of process in Germany. Registration, interoperability, and a couple of those, let's say, IT-specific things in the first step, and then in the second, it's a price negotiation, but also with 2 institutions. Even though, I mean, especially in Germany with the first step, and maybe also here with your first step, I mean, you just said registration. Does that already as well include the presentation, maybe submission of any clinical evidence?
Actually, that's actually in the last step when you go to funding and reimbursement. There you need to submit a kind of mini dossier with clinical data, and especially, which is a very specific requirement, is that you need to explain how your mobile app will change I'm looking for the word in English, a care path, actually, a care pathway in clinical practice. So you have actually to show that you have a kind of impact in daily clinical practice with your mobile app. And then on that basis, a special working group within the RISIF, within the payer body, will decide about the funding of your mobile app.
Okay. And when we're speaking about, I guess the other way around, I think you just said that you need to submit a kind of, let's call it dossier light or something, right? Probably an evidence summary or so. Is there the requirement for an RCT or any kind of, let's say, strong clinical evidence, or is it rather really focusing on what you just said more in the last part of your answer, maybe focusing more on, let's say, the place in therapy in Belgium?
Yes, that's rather the focus. To be honest, we don't have experience yet with the system, so we didn't jump into the details yet of those applications. So we just studied it top line. But as I've seen it, that's the major criterion, is that you have to show that your impact in clinical practice, in daily clinical practice, what's in the care trajectory, actually, the care pathway.
Okay, and this is then more on a theoretical basis, so meaning you take guidelines and maybe information expert opinions, or is it rather you need to register first in the first step, let's say, maybe also go through the second step on the interoperability, and then finally you need already to get some kind of, let's say, experiences as well on the market, I guess then probably for free, or is it rather to say register it, submit your kind of idea on how, let's say, your digital health application would have an impact, and then go into the negotiations?
Yeah, actually, that's the thing. So it's actually more on, as I see it now, but it lacks, of course, the practice, because then in the practice you learn how the theory works. But in theory, if I looked at it at theory, it's more from a theoretical point of view. Of course, it needs to be checked with the field, of course, but it's not that you need to have a mass of data yet. That's how I see it now.
Okay, got you. And do you already know anything like the kind of lengths for that kind of agreement, maybe on the pricing and funding bit? Is that maybe linked then to further evidence generation?
Not to my knowledge. No, it's not a conditional approval. No, not to my knowledge.
Okay, very interesting. Yeah, I think that there are some similarities, let's say, to the German environment, but I think it still sounds a bit more relaxed, I think. I mean, we have quite strong requirements for the clinical part. You would also need to, let's say, further submit hard kind of, let's say, evidence, including at least a comparable or a comparative kind of study, randomization ideally as well. Do you know anything already on, let's say, the potential price levels you would expect in Belgium?
No, not at all. No, it's actually more. It feels more like a pilot. It's not. It's actually an official published, let's say, adaptation of the law. But in practice, it feels still like a pilot phase where you have to try and see how it works and what kind of. There are no. It's like you say. It's not that. The process is not that strictly regulated yet. As probably that will be a development, but it's not for the moment. It's not so. So it's like I don't have any insights in what kind of level of payment that would be.
Okay, interesting. I mean, if we switch a bit, let's say outside of the process, do you have any information on perceptions on digital healthcare, for example, from physicians, patients, but maybe also from the other side, let's say from the payers in Belgium?
Yeah, it's actually very strange, actually, or a bit not really normal that in Belgium they are so quick with this kind of framework. I would call it rather a framework because the regulations are not that strict. So it's rather unusual to have that kind of framework already relatively early in the existence of the mobile apps. So from that perspective, it's you see that there is a strong willingness to create more regulations around those new technologies, let's say, which is a bit in contrast with the other regulations that are a bit slow compared to this one.
Okay, that sounds also quite interesting. I mean, what we see currently, and I mean, as already said earlier, we have the process now since roughly a year. We have now 11 digital health applications which have been, let's say, approved and are also being funded already through that kind of process. But we also see, let's say, a bit, I would say, maybe reluctance also from the physicians to prescribe it. Quite clearly also, maybe on top of that, health insurance companies are also complaining a bit about, from their perspective, high prices. Which might obviously have as well an influence. I don't know whether anything like that has already at least also been discussed in Belgium.
No, not to my knowledge. It's really in the early days, and I think it will be the same. Looking at my experience and feeling the environment, I think that will be the same problem in Belgium too. But to be honest, I don't have insights as we didn't. As we just have the framework in place, we need to build up experience in that. So, and I didn't hear from other people whether it's really working in clinical practice. Of course, the my sugar apps and that are things in diabetes. We are in Belgium already. Let's say there is already a longer trajectory. Because of the fact that there is already an existing care path for diabetes type 2 patients since, I think it's already 5 or 6 years, which is actually a kind of, disease management plan in that. So the apps that are related to that are already, I think they are, installed in clinical practice. But for the rest, I don't know. The newer apps, I don't. That needs to be seen in the upcoming time.
Yeah, for sure. I mean, you mentioned the diabetes example, and I mean, if I follow you correctly, I mean, I think the important component also for the future digital health applications, especially to find, let's say, the place in the whole kind of, let's say, patient pathway, right? Is that then a dedicated, let's say, reimbursement for the digital health application, or is it rather a kind of fixed amount for the whole kind of pathway, and then basically the digital part is just let's say a proportion of those overall fixed costs?
That's exactly how it is for the diabetes. So and I don't know, I think this is the change now in the new system or the new framework that I will. I'm curious to see how they will do it, because it was in the diabetes care pathway. It was actually part of a lump sum, let's say. So the physician gets a lump sum that covers a lot of things. One of the things that is covered is the apps. So there, the problem was not that present.
Okay. Yeah.
And I think this is the change that's going to happen now.
Got you. Okay. I mean, that's great. Maybe just probably the last kind of question. I mean, you just said it was also a bit of a surprise, I think, when it was implemented. Do you think maybe the whole kind of COVID situation has triggered that, especially maybe also to potential further requests on video consultations with physicians?
Yeah, it's a good question. I don't think so, but it will certainly not be counterproductive for this kind of thing. But I don't think it's really driven by that. They already had a plan in place some years ago, and they installed, let's say, level by level of the pyramids, which I explained. So it's actually it was a bit faster implemented due to COVID, but I don't see a major influence. It was actually in plan already some years.
Okay, got you. Perfect. Very good. I think that was great insights. I mean, showing already some similarities, but also some differences in Belgium. So we're also looking forward how the whole kind of implementation will work, and also the kind of, let's say, driving and probably also the kind of perceptions from the physician and patient side. Thank you very much, Katrien de Groote. That was great insights.
Yes.
Looking
My
forward
pleasure.
to further discussions.
Okay. Bye-bye.
That was an episode of MAP, the Market Access podcast provided by Mars Market Access and Pricing Strategy, which is your healthcare consultancy in the German-speaking markets. MAP is available every second week with a new episode, so watch out. And in case you might have questions, contact me directly and or visit our website on www.marketaccess-pricingstrategy.de.